Hello, I'm Dr. R.D. Khare, pediatrician from Mumbai. Today we are going to see how clinically we can evaluate a renal function, and therefore we will concentrate on those aspects of clinical medicine which may be able to guide us for making a diagnosis of a renal disorder or may be able to evaluate the function. The kidney has different parts, the glomerulus, the tubules, the collective systems, and the ureter and bladder and ultimately appendix, urethra, etc. So we'll take one by one. Let us now take the glomerular disease. Glomerular consists of a bunch of blood vessels and then there is the collective capsule. Glomerular disease will give rise to three things in it. Number one, haematuria. Two, mild puffiness of face, and three, hypertension. Now, while we are here, we may talk about haematuria a little bit. In haematuria, we consider three things: cola colored urine, number two, red colored urine, and number three, frank blood in the urine. Now, let us take the second one, which is red colored urine, which may not be true haematuria, and it may be something like dietetic factors like urea or some other thing, or medicines taken which may impart a strong, concentrated yellowish color which may be little irritation. So that is not a true hematuria. Then we go to frank blood in the urine, in which case the color is bright red, there may be clots. It may be as a result of a systemic bleeding disorder, like let us say von Willebrand disease, or it may be as a result of blood coming from the kidney, maybe as a result of renal vein thrombosis or a vascular malformation, but more often because of some stones either landed in the ureter or bladder, and therefore this is a lower urinary tract bleeding and often painful bleeding. As against that, as we will see now, the glomerular bleeding is upper urinary tract bleeding and is usually painless. Because the RBCs are so to say deformed because of the damaged vasculature of the blood vessel, therefore they give rise to hemolysis and the color of the urine becomes cola color. Now when we have this triad, as we say, of puffiness, hematuria and hypertension, and we are thinking of glomerular disease, let us see whether clinically we can narrow down to different even histological diagnosis of a renal disorder. We know that there is hypertension, hematuria or liguria as a result of so-called acute glomerular nephritis. There may be a history of sore throat earlier or pyoderma, and that is the commonest variety of post-streptococcal glomerular nephritis. And here from the history, we have made a diagnosis of PSGN. Or there may be recurrent hematuria, and the patient may be relatively all right in between. There may be a family history of hematuria. Otherwise, the patient may be relatively all right when there is no hematuria, and this could be IgA nephropathy, which is not uncommon in children. And from the history of so-called recurrent hematuria, familial tendency, we have diagnosed this as IgA nephropathy from the history. Then we have a systemic disorder giving rise to glomerulopathy in the form of fever, ill health, not doing well, constitutional symptoms, body ache, joint pains, and malar rash, as we can imagine in lupus nephritis. And from the history, we have been able to diagnose lupus nephritis. Then we think of a disorder where the patient has palpable purpura and maybe some joint manifestations, and he has hematuria, and it is known as inoxon length purpura. And here again we have made a diagnosis from the clinical analysis of the history. We can also have hematuria as a result of Alport syndrome, where it's associated with deafness and there may be a family history, or you can have hematuria or liguria secondary to a disease which is there earlier, the form of hemolytic uremic syndrome. So we have from the history diagnosed different causes of glomerulopathy, and this is what we want to do. Now glomerulus, as we saw, has another function of filtering and not allowing protein to leak. And we know that there is a massive leak of albumin in urine, and we know it is nephrotic syndrome. Now nephrotic syndrome is too common and we know them all. But from the history, what important factors about nephrotic syndrome we will know? We know that in the mid-child age group, most commonly it is the steroid sensitive nephrotic syndrome, and we will agree that children with steroid sensitive nephrotic syndrome or even adults are happy people. They may be edematous, but otherwise they are happy moving about doing everything. So anything which disturbs their general health or happiness is likely to be associated with complication. And the important complications for a nephrotic syndrome is infection. And therefore a small child is now complaining of mild abdominal pain and a little bit of fever and is not doing as well as earlier. And I will think of primary peritonitis. Or if the child has a little headache and is not doing well, maybe I will think of vasculopathy or thrombotic phenomenon like will occur with renal vein thrombosis and haematuria. So infections and thrombotic episodes or thrombotic tendency is something which we'll keep in mind. And last but not the least, these children are already hypovolemic because of loss of so much of protein. Therefore, a child who has edema and has vomiting and dehydration and is already hypovolemic, it may not be very easy to diagnose dehydration in a child, edematous child with nephrotic syndrome. And here the history gives us that vomiting, loose motions, and the child is lethargic. The oliguria may or may not be there, and he may have tachycardia. And in a child with tachycardia and lethargy, and if at all you are able to do the vaccine called ECV and a little hypotension, then you would diagnose hypovolemia and take care to see that the child's hydration is corrected. So these are the factors about nephrotic syndrome where the history will warn us about the emergency that is likely to occur. From glomerulus, now we come down to lower part of the kidney and we take the all important urinary tract infection. And we know that usually urgency, frequency, dyspnea, fever, pyuria, etc. are features of urinary tract infection. In an older person, maybe prostate or retentive, different causes are there. Now, what is important is us is a child who is an infant and present with very high fever, but non-specific fever is not good. He is a sick child, high fever, no urinary stats in front. Child less than 1 year of age. Think of pyelonephritis as an important cause. And unless you think of it, you will not ask for a urine examination, and pyelonephritis may in future predispose the child to renal scarring. So in urinary tract infection in infancy, acute pyelonephritis. And another thing that we must consider in urinary tract infection is what keeps the urinary tract infection going. Oh, it is the voiding disturbances and bowel bladder disturbance. We must ask for history of constipation in every child with urinary tract infection, because constipation will add to infection and will keep the urinary tract persistent, and also voiding disturbances like urgency, frequency, enuresis, and other voiding disturbance, hesitancy. They may add to the UTI in a child who may just have a primary vesico-ureteric reflux and his prognosis is good, but presence of voiding disturbances and bowel bladder disturbances will make the diagnosis of what is known as difficult to treat urinary tract infection, and will be able to prevent the complications that are likely to occur. Having considered these three common conditions, then we go to the other part of the kidney, the tubules. And what are the tubular diseases and how can they present? Well, polyuria, polydipsia, and failure to thrive is the hallmark of so-called renal renal tubular acidosis. They are not very easily available for examination. But these three features in a child who is otherwise well, his feeding is well, he is otherwise, then why is he not gaining weight? Why has he failure to thrive? He has no feature. And he is vomiting, he is loose motion, he is vomiting and passing in, and that polyuria may not be realized, and the child is admitted with dehydration, and one wonders a child with dehydration is passing so much of urine, and that gives us a diagnosis and clue that it may be polyuria. So polyuria, polydipsia, failure to thrive, and in addition other features of urinary tract infection. Those features may be different. For example, proximal RTA may give rise to rickets, for example, and part of Fanconi syndrome. And distal RTA may make them more prone for hypovolemia. Please remember, it's an important thing to know about renal tubular rickets. And in distal type of ricket, they may be hypovolemic, and they may have more than hypovolemic, they have hypokalemia, and they may have recurrent periodic paralysis or weakness due to hypokalemia, and therefore hypokalemia and periodic paralysis as a manifestation of distal RTA is to be kept in mind. And finally, we go to what is known as renal lithiasis, where kidney stone, which is not an uncommon thing. All the kidney stones in children and adults must be investigated properly, because often there will be an underlying cause. They are easy to diagnose. There will be fever, other features of UTI, bleeding, or sometimes they may be picked up only accidentally on ultrasound done for some other thing. The stone is in the pelvis of the kidney, then it may have little dull aching pain, little lower down it may have episodic severe headache, then urinary colic, and in the bladder it may have suprapubic symptom. But important thing to be remembered about stone is hypercalciuria. These children, the diagnosis of stone may not be very easy, and they may have just recurrent hematuria or some pain, some dysuria, and a urine examination may be normal because increased amount of calcium may not be very apparent there. There may be some few RBCs which may be ignored, and unless you know the calcium creatinine ratio, you will not be able to pick up hypercalciuria, and picked up early, you can prevent further damage to the kidney due to further stone formation which will take place later. So these are some of the clues to the diagnosis of structural renal disease, functional renal disease, just from the physical examination and history that we took so nicely. Thank you very much.